Hello everyone, welcome back to my channel. So today we are going to continue ECG lesson. Okay, so today we are going to discuss one is ST segment elevation and acute coronary syndrome. Okay, so ST segment elevation. So ST segment is normally isoelectric, as I have discussed already in my previous videos. Okay, so what are the causes of ST elevation on ECG? Okay, so first of all, it can be a normal variant in some people, especially I think it is seen in athletes. Okay, where actually it signifies early repolarization. Okay, so it can be a normal variant. Okay, now pathologically it can be divided cause pathologically cause can be divided into two parts. Okay, first is heart, second is systemic. Okay, so I'll discuss systemic is very like two important things. First is electrolyte abnormalities. Okay, especially hypokalemia that I'll discuss in my next video. Okay, more than hypocalcemia and hypomagnesemia. And the second is hypothermia. Okay, so these two are important cause for ST elevation that we'll discuss. Okay, now about heart, we can divide it into two parts. First is pericardium. Okay, and second is myocardium. Okay, so as you know, there are three parts: epicardium, myocardium, and pericardium. So, if any disease is affecting pericardium or myocardium, it can lead to ST elevation, especially pericarditis. Only cause leading to ST elevation. Main here is myocardium. Okay, so causes of myocardium diseases that can lead to ST elevation. First is most important: ST elevation MI. That means infarction. Okay, that means infarct. Second is ischemia only, no infarct developed yet. Only ischemia can also lead to ST elevation. Okay. Third is post infarct. Okay, that is LV aneurysm that I'll discuss in my next slide. Fourth can be myocarditis. So infection or inflammation of myocardium can also lead to ST elevation on ECG. Fifth is trauma or tumor. Okay, so these are the causes of ST elevation on ECG. Now we'll discuss ST elevation MI. So to discuss ST elevation MI, we'll discuss acute coronary syndrome. Okay, so what is acute coronary syndrome? The definition, the word itself has acute. Okay, so now let's assume there's a patient who has chest pain, which is very typical anginal chest pain, as we have discussed in angina video. Okay, now angina I have discussed, it can be stable or it can be unstable. So first of all, stable angina I have already discussed that chest pain when it occurs on exertion. So a person comes with a complaint of chest pain and it has occurred on exertion. Patient has already rested for 20 to 30 minutes or taken nitrate at least 3 times within 5 minutes of gap. Okay, after resting for at least 20 to 30 minutes or taking nitrates 3 times, after that also that chest pain has not been relieved. Okay, so that's what is definition of acute. Now we will label it as after 20 minutes. If chest pain is still persisting, we can label it as ACS. So now you patient comes to you after 30 minutes of chest pain. What you do first is ECG. Okay, so each ECG will give you two things. Okay, if you are suspecting myocardial cause, it can be either ST elevation, MI, or it can be a non-ST elevation. Now, this terminology, instead of STEMI, it has become ACS, NSTE ACS. It can be divided into two parts, unstable angina and NSTEMI. Okay, so how we will decide now if ECG is showing any abnormality related to ST changes or TE wave changes, we'll do cardiac biomarker. Okay, we like in my setup I commonly do troponin I, sometimes it is also troponin T. Okay, so now what will happen to troponin I? So if it is ST elevation, okay, and you do trop I which is coming to be positive, you diagnose as ST elevation MI. Now if trop I is positive and there is ST, it's not ST elevation, it is ST segment depression or T wave inversion. Okay, any of these two, then it is NSTEMI. If it is ST elevation, ST segment depression and T wave inversion, okay, but tropi is negative, then it is unstable angina. So patient comes to you with chest pain which is lasting for more than 20 minutes. You do ECG. ECG is either showing ST elevation or it is showing ST segment depression T or T wave inversion. You do tropi. If tropi is positive, then basically in NSTE-ACS, this is differentiated by troponin I or any cardiac biomarker. If it is positive, then it is and STEMI. If it is negative, then it is diagnosed as unstable angina. So basically, what does it mean is that and STEMI. Okay, these are two infarction. Infarction means there is a necrosis of myocardium. Okay, so it is myocardial necrosis. Okay, so basically this is what it shows. Okay, so it is myocardial necrosis, and unstable angina is actually ischemia, okay, which is prolonged than needed. Okay, so stable angina is also ischemia, but that ischemia is resolved either by exercise or by nitrate. But in unstable angina, that ischemia persists, and but there is no necrosis, there is no cell death. That's why there is tropi is negative. So that is what is the basics. Okay, so I hope I am clear here. Okay, so we'll discuss what changes we see in STEMI. Okay, if it is ST elevation myocardial infarction. Okay, so first of all, hyperacute. First change will be, it's called hyperacute change, tall T waves. Okay, so there will be tall T waves. There another cause of tall T wave is hyperkalemia, so we always rule out that. Okay, if you have tall T wave on ECG, so two things you have to rule out. One is hyperkalemia, one is ST elevation MI. How will you know that it is ST elevation MI? Only on the basis of ECG. You repeat the ECG after a few minutes. Okay, so always in myocardial infarction, if infarction is still going on, there will be dynamic changes on ECG. So after a few minutes, if you repeat it, it can be ST segment elevation you will see. Okay, remember this ST elevation will be convex in shape. I'll show you in the figure in next slide. Then what happens, there will be appearance of Q wave. Okay, this all waves I have discussed already in my video of ECG. With Q wave, R wave starts becoming small. Okay, then ST becomes normal. That means that infarction, that means that these are all dynamic changes of infarction. So infarction is becoming chronic now. ST segment will become normal, T wave will become inverted, and Q wave will become QS. So what happens is, this is a normal ECG, QRS and T wave. So I have already told you Q wave can be normal, but it cannot be no more than 0.1 millivolt the amplitude. So what happens is, first is T wave. So first will be, there will be hyperacute. This is your hyperacute T wave. Okay, just a schematic diagram. Okay, then what happens? There will be ST elevation. There will be ST elevation with T wave. T waves will be like that. Then there will be appearance of Q wave. Q wave will increase in amplitude. Okay, and R wave will decrease in amplitude, and ST segment will be here only, and there is a possibility that T wave inversion will start appearing. Okay, and last is, there will be QS pattern. What is QS pattern? This is P wave, this is QS. T wave can be inverted or can again become normal. So it depends on the extent of damage. Okay, so as you can see, this is called QS pattern, means there is no R wave, no R wave. This is called QS pattern. Okay, so if patient comes to us with QS pattern, that means already infarction has occurred. There is no role of thrombolysis in this. Okay, when you will read ST elevation MI, when you will read the treatment of it, there is no need of thrombolysis in this. Okay, so this ST segment will become normal, T wave will become inverted. Eventually there's a possibility that T wave can also become normal, but QS or Q wave always persists. Okay, so this is ST elevation MI. Okay, in non ST elevation MI, what do you see? NSTEMI or UA, that is NSTE ACS, you will see T wave inversion is more common than ST segment depression. Okay, remember this. T wave is actually more than 0.2 millivolt. It is quite deep in ischemia or infarct. Okay, remember. Fine. So this is clear. Okay. Okay. So now as we have discussed this STEMI, so I'll just show you the ECG. As you can see it here, this is convex shape ST segment. Okay. And okay, this is ST elevation MI. Now, one more thing, there are three things here that we are going to discuss now for ST elevation that appears same. So as I told you, in dynamic changes of ECG for ST elevation, okay, ST segment will become normal. Okay, but if it persists, ST segment elevation, persistent ST segment elevation. Okay, if it persists even after 24 hours, 48 hours, then on especially at the end of 2 weeks, okay, at the end of 1 week or 2 weeks, then we suspect LV aneurysm. Okay, so because of the area of the myocardium that is infarcted, there is a scarring and there is a aneurysm of that area, and that's why there will be persistent ST elevation. So I have already discussed this also, that ST elevation, in which leads you will see the ST elevation. So according to the artery, it will be the leads will be affected. So if it is inferior wall, there will be 2-3 AVF ST elevation. If it is anterolateral wall, then it will be 1 AVL or V2 to V6. Okay, if it is enteroseptal, then it can be V1 to V4, and if it is only lateral, then 1 AVL, V5, V6. So these are all your walls depending on the arteries, and that will affect your leads. Okay, so this persistent elevation in LV aneurysm will also depend on the artery that is affected. Okay, so this is how you differentiate LV aneurysm. This is how you say that it is LV aneurysm and it is ST elevation. So at the end, after 2 weeks of ST elevation, okay, there is a history of ST elevation MI, and after 2 weeks you see the ECG, there is an ST elevation, there is a persistent ST elevation, then you could suspect LV aneurysm and we get the echocardiography done. Okay, so how will you differentiate whether it is a newly developed ST elevation or whether it is LV aneurysm? So again, I told you there will be a dynamic changes in STEMI, there will be non-dynamic changes, it will be same. And as I told you in the previous slide, that ST elevation MI, there will be Q wave appearing. Okay, so it is possible in STEMI that Q wave has still not appeared, there is still that dynamic changes to be appeared, but in LV aneurysm there will be Q or QS pattern is always present. Okay, always present, it can be plus minus. Okay, so this is the two changes that, and yeah, one more thing, this also I have discussed in my ECG, that in STEMI, okay, if anterior wall is affected, then posterior wall or inferior wall will show reciprocal changes. So for example, if it is anteroseptal MI, okay, so V1 to V4 will be showing ST elevation. Okay, so there's a possibility that in a posterior wall or in the inferior wall there will be ST segment depression. This is called reciprocal changes. Okay, because the electrodes are away from that wall. Okay, so reciprocal changes will be seen here. It won't be there in LV aneurysm. Absent. Reciprocal changes will be absent in LV aneurysm. Okay, so one more differential diagnosis if there is ST elevation is pericarditis. So how will you differentiate whether it is STEMI or LV aneurysm? So again, there will be no reciprocal changes in pericarditis. There will be global ST elevation. Remember this. There will be global ST elevation in all the leads where there will be ST elevation. Then there will be the shape of the ST elevation. As I told you, there will be convex shape here, convex ST elevation. Here it will be concave, or we call it saddle shape ST elevation. Okay. Okay, there will be no reciprocal changes, there will be global ST elevation, there will be concave or saddle shape ST elevation, and the changes will be non-dynamic. And one more finding we see is PR segment depression. Okay, this is most specific for pericarditis. So most common finding of ECG of pericarditis is global ST elevation, but more specific is PR segment depression. Okay, so this is what we will see. Okay, so I hope I am clear between the differences. So how will you differentiate pericarditis and LV aneurysm? So LV aneurysm, only few leads according to the artery affected in ST elevation MI, it will show ST elevation. pericarditis will be global ST elevation. Again, both will show no reciprocal changes, and the shape of the ST elevation will be different in LV aneurysm. It will be convex according to the STEMI. Okay, it will be non-dynamic, and there will be PR segment depression. If there is PR segment depression with global ST elevation, it is acute pericarditis. Okay, I hope I am clear here. Okay, this ECG I have already showed you. This I have already discussed with you. Now, LV aneurysm. See, as you can see, this is QS pattern. This is QS pattern. Okay, there is no R wave, there is only Q. So Q and S together become QS pattern. And as you can see, the ST elevation is convex. Okay, like we saw in STEMI. This is convex. Okay, there is no concave. When I show you pericarditis ECG, you will understand. Okay. So again, this is convex, and it is not very, see, only one or two segment ST elevation is in one or two small box, one box only ST elevation is present. Okay, and there is QS wave. Okay, and there is no reciprocal changes. You can see V1 to V3 is affected here. There is also T wave inversion, the part of the changes of STMI, but there is no this there is no reciprocal changes. Okay. This is pericarditis. Now this is, as you can see, this the first part of the ST elevation is concave here. Okay, this is concave. It's also called saddle shape. Saddle shape. Okay, so basically the ST elevation will be this way. This is a concavity that is present here. Okay, and as you can see, there is a PR segment. You can see PR segment depression. This is P wave. This is Q wave that is starting. So what is PR segment? Between the P wave and the QRS, there is a PR segment that you can see it is depressed. Okay, so this depression is seen. You can see it is depressed. So this is the most specific sign of pericarditis. Okay, and as you can see, there is a global ST elevation here. This is also affected. This is also affected. So it is a common finding of essential. Okay. Thank you so much. In the next slide, we'll discuss two more topics of ECG. And if you like my video, please like, share, and subscribe. Thank you.